students, welcome to today's class on leptospirosis and syphilitic uveitis. At the end of this class, you will be familiar with the clinical manifestations of leptospirosis and syphilis. You can wonder, why leptospirosis? Is it common? We know syphilis, but we do not know leptospirosis. Then why is it included in this class and in this session? I'll tell you why. See, leptospirosis, syphilis and Lyme's, all the three are spirochetes. All the three spirochetes causes uveitis. Surprisingly, syphilis is there throughout the world, so every one of us know what is syphilis. Even though we are not seeing many cases of syphilis, at least we have heard syphilis repeatedly. Lyme's is there only in Western countries, not in our country. We have not seen even single case of Lyme's. Maybe in Bangalore, somebody near forest had reported Lyme's, 1 or 2 cases, that's all. Whereas leptospirosis is very common in India. Not only in India, in all tropical countries, in developing countries where infrastructure is poor, the leptospirosis is there. But unfortunately, we do not know. Many of the doctors do not know leptospirosis. I recently made a study and found out only 18% of postgraduate doctors know about the term leptospirosis, and 14% of doctors, undergraduates, know about leptospirosis, and that too, they knew only that it is a spirochetal disease. Not the clinical manifestation, not the treatment. It was very surprising, and we got it published also. So you can see that publication in one of the slides here. And anyway, now we know that leptospirosis, syphilis, Lyme's are all 3 spirochetes, and one another similarity is all the 3 have 3 stages in the disease process. The first stage, primary or symptomatic or asymptomatic. In leptospirosis also, at the time of infection, patient may get fever or may not get fever, and then that is followed by a secondary latent stage of asymptomatic stage, then tertiary stage of uveitis in leptospirosis. Whereas in syphilis, initially you will have a lesion, gamma of either mouth mucosa or genital mucosa, followed by secondary syphilis where rashes are there all over the body, tertiary syphilis of CNS syphilis. In Lyme's, you have that primary tick bite and erythematous patch, followed by secondary latent stage, tertiary uveitis. So these 3 stages are there in all the 3 spirocheta. So we will be seeing only leptospirosis and syphilis because Lyme's we don't see in India. We are not going to talk about that. This is a Leptospira bacteria seen under electron microscope. This looks like a hooked S-like organism, and this grows only in EMJH media. This will not grow in blood agar, this will not grow in chocolate agar or PDA, not in any of these media, only EMJH. It is a liquid media, and this is a motile organism. It will be wonderful to see under microscope. It will be seen only under dark field microscope. That is the reason we do not know. We know staphylococcus, everything, because with gram stain you see with ordinary microscope you will be seeing, but here you need a special microscope, dark microscope, or you need a fluorescent microscope, and these organisms live only in EMJH media, not in routine media. So you have to have right media and you have to have right microscope. Then when you see, it dances because it is motile. And see the dark background and the refractile bodies are dancing. Isn't it wonderful to have only background music to enjoy that? And it is a beautiful experience to see Leptospira cultures. By chance, if you go to any Leptospira lab, ask them to show the leptospires, living leptospires. It is beautiful to see. And this is the topic I mentioned, knowledge, attitude, practice towards leptospirosis among undergraduate and postgraduate medical students in India. You can go and refer, and it is only 14 to 18% of doctors know something about leptospirosis. So now you have to be really attentive to the class and know everything that you need. This is a waterborne zoonotic disease, which means the disease comes from animals. Okay, that is the reason I selected this background, and this is very common in tropical climate. Whenever there is a 37 degree centigrade, then it is common. And you know our Madurai environment is 37 degrees. Madurai and South Andhra, Kerala, Calcutta, Mumbai, Gujarat, all these areas, environmental temperature at some point of time is 30 to 35 or 37. So this can live in the water, stagnant water, and it is in fact suitable, those places are suitable for leptospirosis, not for humans. And Madurai, we had a very big epidemic. Tamil Nadu, many places are endemic places. Andhra, Nellore is endemic place. Kerala is endemic place. There are many places in South India, they are endemic places for leptospirosis. And this lives happily in paddy field. These small animals carry leptospirosis throughout life. Rats are carrying leptospirosis in their urine, in their bladder throughout life, and it excretes and contaminates the paddy field, and larger animals are reservoirs. So this can also excrete millions of leptospires when they urinate once. So the whole paddy field will be soaked with leptospirosis. Unfortunately, our poor farmer will not have any shoes, protective shoes, and they think that it is not respect to go with the shoe in the paddy field, so they go without any protective footwear. In tropical climate, in the paddy field, with the field rat and the field cattle, this man is absolutely in danger. And unfortunately, this affects poor people. So it has not come into light at all, because it is not causing high cholesterol as in rich people. So that is the reason we do not know about the disease. And is it only seen in farmers? No, not at all. In farmers, it is very common, and it is also common in rural areas where animal and human live together. See, in the same place, we can see people living together, and same water they use. That is the reason it is common in rural areas. Is it uncommon in urban areas? No, not at all. It is common in urban areas when drainage fails. So rich people don't get it. Only poor people get it. People live in slums, unfortunately prone for this disease. In that population, it is endemic. Unfortunately, this is diagnosed as fever. That's all. Nobody diagnoses as leptospiral fever. Is it only endemic disease? Not at all. It can come as epidemic in rainy season. In rainy season, animals urinate in the pathway, and environment, it contaminated. Human cross the same pathway. So in rainy season, especially places like Mumbai, Gujarat, Tamil Nadu, Chennai, Nellore, all these places, after rains, they get several cases of leptospirosis. In Kerala also, several places we have leptospirosis. And only in Kerala, they relate this disease with rats. They call it as rat fever. But in Tamil Nadu, even though it is very, very common, people call it as fever. They do not know that it is associated with animal, associated with rat. So this disease has come as outbreaks throughout the world. See, these are all the outbreaks which I have marked. And in 1993 November, Madurai had a biggest outbreak. And all the slides are from those patients. And these patients can be asymptomatic. They can get the disease, they may not have any symptom. They can be quiet. That occurs in many diseases. Or they may die of the disease. So if it is, say for example, if it is TB, patient coughs and blood is coming out, then you know, okay, patient may have pulmonary TB. In jaundice, eyes are always yellow, so you know it is jaundice. So certain diseases you can make out. Diseases like leptospirosis you cannot make out because it is very wide range. Either they are asymptomatic, or they get mild fever, or they get moderate fever, or they get severe fever and die, and it is lethal. 4% of people who get leptospirosis die out of this disease. When they die, all the fluid in the body will have leptospires. Peritoneal fluid, pericardial fluid, serum, urine, all the fluid will have alive leptospirosis. You can put a needle and take a serum and put it under microscope, dark field microscope, you can see these dancing organisms. It is very dangerous in some people. Unfortunately, doctors diagnose as pyrexia of unknown origin. I'll tell you why they are not able to make their correct diagnosis. Some call it as flu, some call it as seasonal fever. They don't come to the right diagnosis of leptospirosis because leptospirosis in initial period can affect any system. It can affect respiratory system, it can affect cardiovascular system, it can affect CNS, it can affect any system for that matter. So symptoms vary a lot depending upon the primary affection. So I'll show you some of the pictures, then you will understand. Some patients will come with circulatory system affection with multi-organ hemorrhage and hypotension. This is very, very, very common. Patient will have hemorrhage everywhere inside. Cardiac tissue will have petechial hemorrhages everywhere. Liver will have petechial hemorrhages. Multi-organ, all the organs will have hemorrhage. So at that time, internal hemorrhage occurs and sudden hypotension, and patient is likely to die in this stage. Doctor will not know at that time that this is leptospirosis. Multi-organ hemorrhage he is not seeing. He is seeing the hypotension only. And patient can have arrhythmia, patient can have cardiac failure and many other things. So because it is not having single clinical sign that is specific for leptospirosis, you will see several systems getting affected and several ways patient getting affected. When respiratory system is affected, patient vomits out blood. It is like tuberculosis. So they make a wrong diagnosis of tuberculosis. It is not their mistake. Disease is causing hemoptysis, which is like tuberculosis. So we are likely to miss the diagnosis. It can at the same time cause consolidation also. Consolidation of the lung. And also respiratory distress, which is common in viral diseases. So it mimics several other diseases. In urinary system, it can cause oliguria. Patient may not pass urine at all. It can cause pyuria, hematuria, bleeding in the urine. It can cause anuria. It can cause swollen pale kidney with petechial hemorrhages everywhere, like this. We can see the hemorrhage. And patient will die of acute renal failure. The diagnosis will be acute renal failure. It will not be leptospirosis. Because it manifests in different way in different patients. Nervous system can get affected. Psychotic behavior is very common. And many of my patients, when they ask them past history, they used to say, some black woman affected me and I had fever and I didn't have right meditation and right thinking. I think I have bad time. Since then, I have now eye problem. So they connected this psychotic behavior with the eye problem. It really happens. And it can cause aseptic meningitis, encephalitis, radiculitis, peripheral neuritis. Not every patient comes with this. Only some patients come with this. Some patients come with respiratory symptom. Some patients come with cardiac system problems. In digestive system, the most important is hepatomegaly and liver failure. As I told you, hepatorenal failure is the cause of death in many patients. And this affects alcoholics. Because their liver is already damaged, it affects alcoholics. It can cause acute adrenal hemorrhage, acute pancreatic hemorrhage. And the very, very funny thing is, this causes muscle tenderness when they have fever. See, when you have fever, it is very common to have myalgia. Muscle pain is common. But these people will have tenderness. If you help them to sit from the bed, they will shout, don't touch me, it's paining. So the muscles are, because they have hemorrhage, once you touch the muscle, they shout out of pain. So skeletal muscle fiber necrosis also happens and hemorrhage in muscle fibers happens. Joints, it causes chronic arthralgia and difficulties in diagnosis. There is no precise diagnostic criteria because it can manifest with any system involvement and varying clinical picture based on the system involvement and lack of laboratory tests in many places and lack of awareness among doctors. All these four things causes difficulty in diagnosis. And late complication is uveitis. So leptospirosis itself is not known to many doctors. How come leptospiral uveitis is known? It's not known. But we have, at that time of epidemic, we had a very big epidemic. They followed by endemicity for more than 5 or 7 years. We had 2,000 cases of seropositive leptospirosis in our hospital. And I told you that it causes arthralgia. It causes hypopia and uveitis. Hypopia and uveitis and arthralgia, when it come together, what will be your differential diagnosis? Either HLA-B27 or Behçet's. Because uveitis and arthralgia, many times my students used to make the diagnosis of Behçet's because this also has fluid level hypopia. So here also we miss the diagnosis. Ophthalmologist also miss the diagnosis. Spirochetal infection, this leptospira uveitis, can also have varying clinical manifestation. It can be unilateral or bilateral. It can be acute uveitis or panuveitis. It could be subclinical, mild or severe. It could be non-granulomatous or granulomatous. There is no single presentation. Varying presentation is seen in this disease. That is the reason doctors miss the diagnosis. Now we will see good clinical images. Sometimes they come with non-granulomatous uveitis with or without hypopyon. And they have rapidly maturing white cortical cataract. See this young boy with unilateral cataract. The other eye is not having cataract, so it's not congenital cataract. But that one eye is having mature white, pearly white cataract. This is leptospirosis. Very, very, very important. I'll show you several other pictures also. So this causes non-granulomatous uveitis in 92% of the patients. And cataract in 21 patients. Posterior synechiae, rarely, see in HLA B27, 90% of the patient, 99% of the patient will have posterior synechiae. Whereas in this disease, it's only 25. Posterior synechiae is slightly rare. And hypopyon is nearly 20% of them will have hypopyon. In anterior segment, hypopyon and cataract is important. And in posterior segment, membranous vitreous opacities. See the membranous opacities, loosely floating membranous opacities and this vitreous exudates. These two are very, very important. Pathognomonic. In fact, when you see vitreous membranes, it is pathognomonic for leptospiral uveitis. Other things are vitreous exudates, vitreous precipitates, pars plana exudates, vitreous cells. All these things happen in vitreous. Other than that, we can have differential diagnosis when you have this membranous vitreous opacities. That is very important, no? ARN can cause vitreous membrane, toxoplasmosis, endophthalmitis, and severe pars-planitis. But how will we differentiate these two? Leptospirosis never causes choroiditis or retinitis. It never touches choroid and retina. It touches the retinal vessel. Retinal vasculitis occurs, but choroid and retinitis and choroiditis never occurs. Whereas ARN always has retinitis. Toxoplasmosis always has retinitis. Endophthalmitis and severe pars-planitis has 4 plus vitreous cells. Leptospirosis also can have 4 plus vitreous cells. So it is little difficult to initially differentiate endophthalmitis, severe pars-planitis, and leptospirosis. And in toxoplasmosis, there is a healed lesion and active lesion. You have vasculitis also, but retinitis and healed lesions are there, so it is different from this picture. Retina and choroid is never affected in leptospirosis. Here, retina and choroid is affected in toxoplasmosis, so you can differentiate toxoplasmosis from leptospirosis. Vasculitis. 30% of them have vasculitis, and this is a typical type of vasculitis, exudative vasculitis. In ARN, you have vasculitis, but this is in Behçet's ARN, you have vasculitis. In Behçet's, you have vasculitis. In CME retinitis and Eales disease. All these diseases, you have vasculitis. In Behçet's, you have pale disc with occlusive vasculitis. Very, very, very typical. In Behçet's, you have pale optic disc and occlusive vasculitis. Whereas in ARN, you have retinitis patch, big tongue-shaped retinitis patch with vasculitis. In CME retinitis, you have hemorrhagic borders. So CME retinitis, hemorrhagic borders. In Eales, you have vasculitis, neovascularization, but you will not have vitreous cells, absence of vitreous cells. So all these things can very well be differentiated from leptospirosis because this has exudative vasculitis, like tuberculosis. Optic disc edema in leptospirosis in 30% of the patients, and differential diagnosis is VKA sympathetic ophthalmia, pars-planitis, TB sarcoid. All these things can cause optic disc edema, but in leptospirosis, you are likely to have vitreous membranes. Whereas in all other things, you will not see vitreous membrane at all. And leptospirosis is acute uveitis and disappear with one course of steroid. After that, usually patient will not come with the recurrence of uveitis. Whereas in VKH and sympathetic ophthalmia, granulomatous uveitis. Leptospirosis is non-granulomatous uveitis. All these things are granulomatous uveitis. So with that, we can differentiate leptospirosis from other diseases. Another example, rapidly maturing cataract. This also we published long back in 2000. There was a wonderful patient who came with right eye immature cataract with hypopyon uveitis. So I told him, uveitis is active, so I cannot operate. I'll give you steroids. We have ruled out all other diseases, and it was leptospiral uveitis. He had hypopyon and non-granulomatous uveitis with cataract. So it was, and we did a serology, and leptospira was positive. I told I will control your uveitis, then we will do surgery. So next, I gave steroids. Next month he comes with absolute, like complete uveitis, white mature cataract, ready to burst, something like that, and partial cataract in the left eye. I was telling, oh my God, you have developed cataract in the other eye also, and the other eye has uveitis also, so now also we cannot operate, so I'll give you steroids, and we will wait for the left eye to come to normal, then we'll do surgery in this eye. He comes next month with partially absorbed cataract in right eye, and fully mature cataract in the other eye. My God, partially absorbed. I was so surprised. How come it gets partially absorbed? I wait for one more month, it got totally absorbed. The reason I had to wait is 3 months you have to wait since the uveitis comes under control, then only you can operate. See, completely got absorbed. This is the picture of that patient. This is only few cataract spots. With the president, he had 6x vision. I told I will operate now. He was telling, no, I didn't. I had minimum vision. Then I lost complete vision. Then I again had minimum vision. Now with the glasses, I am seeing everything clear. We will wait for one more month. Maybe without glass, I will see. I told your disease, Leptospira, can take away your normal lens, but you cannot put intraocular lens. Only doctors has to put the intraocular lens. So we actually put intraocular lens, and he had 6x vision. So spontaneous cataract absorption is a very funny phenomenon in Leptospira uveitis. We recently published another paper. See, all these young people have unilateral cataract. And there is no history of trauma at all. This young girl, no history of trauma. This young boy, no history of trauma. Other eye fundus is absolutely normal. So hypopyon uveitis with cataract. See, cataract with posterior synechiae, cataract with hypopyon. And all these people have other eye clear lens. So we published this case as rapid maturation of cataract in leptospirosis with many examples, and we collected this lens material. We saw under microscope it was bubble degeneration in these lenses, which was different from normal senile cataracts. We have published the lens matter also under histopathological study in 2020 in Indian Journal of Ophthalmology. Those of you interested can see this picture. It is very interesting. The reason I am repeatedly telling, many of these times, these people will get the diagnosis of traumatic cataract. Because it is unilateral and mature cataract, we tell the patient, maybe you had trauma, you have forgotten. Patient is always right. we assume, we may be wrong. So if the patient says that I never had trauma, we have to believe. Then we have to ask their occupation. Maybe they are farmers, or maybe they were living with animals, and maybe they had fever before and uveitis later, then they developed cataract. So we have to get the history properly. So in summary of leptospirosis, hypopyon and cataract in anterior segment is common. Vasculitis, papillitis, vitreous reaction is common in posterior segment. And this was published long back in 1997, American Journal of Ophthalmology. And again, recently, 2018, statistically, we proved comparing leptospiral patients and non-leptospiral patients, and we published major predictors for leptospiral uveitis and minor predictors for leptospiral uveitis. So when the patient is middle-aged farmer, when they have non-granulomatous uveitis, hypopyon, papillitis, vasculitis, vitreous membrane, no choroiditis, no retinitis, then it is leptospiral uveitis. This was published in 2018. Okay, now we have talked enough about clinical presentation. You have to come to the diagnosis, lab test. As I told you, this grows very well in EMJH medium, and it freely motile and dances. You add patient sera, which is supposed to have antibodies when they suffer from leptospirosis, everything will undergo agglutination. So this is pure leptospira culture. This is patient's blood added leptospira culture. This is microagglutination that has happened. Can be seen only under dark field microscope. So that is called microagglutination test. It is very, very expensive to have this test because you have to grow 20 different serowarts. Every week you have to subculture, and the media is expensive. Somebody has to be posted for this because immediately it gets contaminated, so you have to be cautious. So not every lab can have microagglutination test. Commercially available, ELISA test and dot blood test is available. That also you can use for diagnosis. And we have PCR as well. We can diagnose with PCR of aqueous fluid. PCR of aqueous fluid is invasive procedure. Clinical diagnosis is much easy with those diagnostic criteria, so we can diagnose. As I told you, 4% of them die out of the disease, and in such a severe disease, you have to treat with intravenous penicillin or third generation cephalosporins. Minor disease, mild fever, oral doxycycline, 100 mg BD for 10 days. And uveitis, obviously, if it is anterior uveitis, topical steroid. If it is pan-uveitis, unilateral posterior subpenial steroid, bilateral pan-uveitis, systemic steroids. It's very easy. It occurs also in horses. This is out of interest. I'm showing this picture. This is a slit lamp, not ophthalmoscope. This is a slit lamp which is used for horses. Horses cannot keep their chin in the slit lamp. So the slit lamp is changed according to the horse need. And they also develop synechiae, cataract, iris atrophy, retinal detachment, lens subluxation, and corneal opacity. And they become blind. It is very unfortunate because it is extremely expensive to grow these animals, horses. Once they become blind out of leptospirosis, they kill the animals. It is such an economic loss for the owner. So veterinary people knows leptospirosis much, much better than human doctors. In human doctors, even it causes abortion or infertility, it is a money for the doctors. But it causes abortion and infertility in animals, it's a loss for the owners. So veterinary science has studied a lot in leptospirosis. I felt very surprised when I was doing literature search. Okay, this is all about leptospirosis. Now we are coming to syphilis. The surprising fact is, once upon a time, when syphilis was very, very common, doctors were much aware of syphilis, clinical signs and symptoms. They easily diagnosed syphilis. In fact, they overdiagnosed syphilis. They told every uveitis is syphilitic uveitis. After that, penicillin came out. Syphilis was now almost disappeared, and none of the doctors see syphilis often, and many doctors have not seen syphilis at all, so they missed the diagnosis. Now syphilis is back. Because we have HIV outbreak, syphilis is back. We can't afford to miss syphilis. We have to be very, very cautious. But like leptospirosis, this can present in any way. It can be anti-uveitis, it can be pan-uveitis, it can be post-uveitis, it can be non-granulomatous, it can be granulomatous, it can be just retinitis, or it can be vasculitis. So because it comes with different phases, we are likely to miss the diagnosis. And it is not very, very common also because people get treated with penicillin when they have exposure. Only 0.5% of cases in 2018 had positivity in for syphilis, and in 2019, 0.7%. And we are not seeing congenital syphilis at all nowadays because pregnant mother are tested for syphilis and they are treated. So we don't see congenital syphilis. So this is a museum model where congenital syphilis was very common before penicillin era. And this museum model shows frontal bossing, blindness, and we have to imagine that he has deafness, saddle nose, and adjacent teeth. We don't see, I have not seen even a single case, so I don't have a photograph. And syphilitic bone injuries, see gamma of syphilis bone injuries. This also a museum piece in Paris. I have brought these pictures because nobody sees nowadays, no? So I wanted to show you these things. What we see is, this is very, very common, very, very common. When I see this, immediately I look for syphilis. I ask for syphilis and they will definitely have secondary syphilis. And this can happen in syphilis. So we have to be cautious in examining these patients. And secondary syphilis, you can have rashes everywhere, symmetrical rashes. That is also when you are doing systemic examination, you should find out. As I told you, it can come with any phase. It can be iritis or panuveitis, subclinical, mild or severe, granulomatous or non-granulomatous. And some clinical pictures, these are exactly like leptospirosis, they can come with hypopyon uveitis. This is in fact a leptospira patient picture, but I don't have syphilitic hypopyon. It is not that common. But this is truly seropositive syphilitic case, and this is truly seropositive syphilitic case with temporal pallor. The patient is going for tertiary syphilis. Okay, treatment, intravenous penicillin, but with problems with penicillin, so you can have third generation cephalosporins. Oral doxycycline will not work that much, but still third generation cephalosporin is very good. Uveitis anyway like leptospirosis, it's only topical, periocular, systemic steroids, depending upon the anatomical location. So now we are coming to the end. Leptospirosis, a very common spirochetal disease, common in our poor farmers. We are not supposed to miss this diagnosis. Syphilis is less common, but still it causes uveitis. And when you ask history of exposure, nobody is going to say that I'm exposed. So every case, unfortunately, it is very cheap. So we test for syphilis because history is not really helpful. So students, I hope this session on syphilis and leptospirosis was useful to you. Thank you.